First, I just want to say thank you for inviting me. It's been already a lovely experience. This is my third time to Iceland, and one of the great things for me coming here, there's really two parts. One, I'm always treated so well. It's a very warm place to come. And also I can learn about what is the nature of the discussion, what's happening in your society and how things are changing. I first came here in 2011 and then in 2017 at the invitation of Mind Power. And not only learning about what they were doing, but also getting a sense of what was the narrative that was sort of circulating within Iceland at that time. And one of the big surprises for me today was how involved IPS is now in the Iceland society, which is a great thing to see. So I'm just going to tell you, you have a bit of an obligation. I was here in 2011, 2017, 2023. I'm expecting an invitation in 2029. The theme of this, a new way of thinking about mental health, is, I think, such a great thing because it allows for this sort of investigation, this sort of discussion. What is the narrative that has governed our thinking in society for the past, well, let's look at the past 40 years. And we can look at, has that narrative served us well? What is the narrative? Has it served us well? How's it affected in terms of like the burden of psychiatric distress in society? What are clinical outcomes? And is it scientifically grounded? Now you have here a thing that's saying that, well, you see where I'm going with this. If that narrative hasn't worked, and what does the evidence show, what narrative are we going to replace it with? What are the opportunities for a new narrative to guide our thinking? And so, what I'm going to do today is look at the narrative we've had, look at the outcomes with that narrative, sort of talk about what is the vision for a new narrative that is possible, that is actually has been circulating around here all day today, and from what I gather in the workshops, was circulating yesterday a very different narrative. By the way, I love these little video descriptions, stories we've read. They're all telling of a different narrative. All telling of a different narrative. Then I want to look at, as we think of a different narrative, are there times in the past where this narrative took hold? And what did we see happen when that narrative took hold? A different narrative, the one we're going to come back to. And then look at ongoing experiments that really are, we heard from Magnus, for example, the medication-free treatment in northern Norway, or in Norway. That's really based on a different narrative of what is possible in terms of conception of people, what's wrong, and also though is what can you really happen long-term for people. And then finally, what I really want to emphasize here is one of the things I love about coming to Iceland, and you're a small country, you're 400,000 people roughly, isn't that right? You have a chance to be a laboratory for change that will be a model for others. Because you have access to your politicians, you're a small country, you can make changes that will be viewed by people on the outside, like in the United States, and can be for us a model of what is possible. So that's how I hope to finish this day. And by the way, I really love the talks today too. It's actually changed some of what I'm going to say. So what is the narrative we've had, that we've organized our thinking around? You heard from both James and Andrew, the date 1980. 1980 was a big change. So what happens in 1980, DSM-3 is published. That's the third edition of Diagnostic and Statistical Manual. But at that time it happens, American psychiatry is changing the narrative. So if you go into DSM-1 and DSM-2, there was some sense that some were biological disorders, but a lot of the descriptions were reactions to the environment, okay? And if you have reactions to the environment, you're not really saying people are chronically ill, et cetera. But in 1980, the American Psychiatric Association decided to adopt they call it a medical model. It's not. It's a disease model. They decided we're going to call all these things diseases of the brain that exist inside the individual. And they also, the part of the story they're going to tell is that bipolar is distinct from schizophrenia, as like heart disease is from cancer, that these are discrete, specific illnesses that reside in the brain. Now, one of the things that is important to know, this change in conception that they embraced in 1980 was not born of scientific discoveries. There were no discoveries of the disease elements in different categories. They did it really in order to present a new image to society. an image of psychiatrists who wore white coats. Because in the 1970s, there was a lot of sort of questioning of the credibility of psychiatrists as a medical discipline. If you go into their archives, they talked about, we're fighting for our survival, and they said, how can we restore, or not even more than restore, present an image of that is so cherished in society? And they said, we'll put on the white coat, because medical doctors have this sort of very sort of exalted place, or at least for a long time, in society. So they said, we will consider these diseases of the brain and we'll present this new model to the American public. There was a famous book in 1994 that was published by Nancy Andreasen, who was the future editor-in-chief of the American Journal of Psychiatry, called The Broken Brain. And what did she say? Because this was when this was presented to American society. She said, these are discrete illnesses, and here comes, and there's a lot of evidence they're due to chemical imbalances in the brain. Now, that is a disease model, if you say that there's something physically wrong in the brain, and then very quickly we're going to start to hear, and maybe the drugs can fix that, like insulin for diabetes. That's a disease model. You have to read a book, and that became, I remember reading that book and go, wow, this is a new way of thinking about myself. Because you have these neurotransmitters that sort of determine whether you're happy or sad or whatever, and they're really governing who you are. And this idea begins to take hold in the American public. In 1986, there was a series run in the Baltimore Sun, and it said, psychiatrists are discovering the very molecules that govern our brains. Okay? Prozac comes to market in 1987, 1988, and it's announced as, it's presented as this breakthrough medication, this wonder drug that fixes the chemical imbalance, and now people can even be better than well, is what we heard. So this is a story of great progress. Then when we get atypical antipsychotics, these are these new antipsychotics like Zyprexa, risperidone, they're said also to be breakthrough medications. They fix multiple chemical imbalances in the brain. That's what was told at the time. So we get this story of progress in fighting a disease, okay? I just want to note one thing with the conception of this. You're either normal or abnormal, right? You either have a discrete illness, and you're mentally ill, or you don't, okay? So there's some line that is being drawn between those who have it and those who do not. Now, in terms of telling this story, it does really arise with the American Psychiatric Association. As James said, the pharmaceutical companies really loved this story too, because they understood this was going to open up all these sort of ordinary discontents, turn them into illnesses, and expand the market for psychiatric drugs. So beginning in the 1980s, what you see is a lot of money going from pharmaceutical companies to academic psychiatrists who already want to tell this story, and so you get this joining of an academic prestigious group with a powerful commercial group to sell this story of chemical imbalances and drugs that are breakthrough medications. And by the late 1990s, when the New England Journal of Medicine was trying to do a review of antidepressants, they looked for experts in mood disorders who did not take, in the United States, did not take money from pharmaceutical companies, and they almost couldn't find anyone. So that's the storytelling apparatus that emerged in the 1980s and 1990s. It does take hold in the United States, and then it's really exported around the world. It's exported to you, it's exported through Europe, it's exported to South America, and increasingly to Asia, okay? Now, one of the key things about this is an incredible story of medical progress. Think about how complex the human brain is, right? It's the most complex thing in the universe. And researchers apparently had uncovered the very molecule that caused madness, the very molecule that caused depression, the very molecule apparently that made kids unhappy with school, ADHD. And they could fix it. And if that is true, I would say that's the greatest medical discovery in history, and actually one of the greatest scientific discoveries in history, if you really can know the molecule that causes, quote, madness or depression, etc. And as this story was told, we get this great expansion of the psychiatric enterprise. First of all, in in 1987, we in the United States spent about $800 million on psychiatric drugs. I don't know the percentage of people who were taking drugs, because there were a lot of people taking benzodiazepines, but 50 years, that's 1987. In 2007, 20 years later, we were spending about $40 billion on psychiatric drugs. That's a 50-fold increase in the market or spending. And today, we have at least 20% of our population on psychiatric drugs on a daily basis. If you go to our colleges, anywhere from 25 to 30% of entering freshmen now have a diagnosis and have a prescription. So you can see this great expansion of the psychiatric enterprise. Theoretically means more and more people are getting treated for a disease. So that's the story we organized ourselves. That's the big picture narrative that was sold to us all. Now we want to look at, is it true? That's number one. We want to look at what are the public health outcomes and what are the clinical outcomes that we see with this. Well, the big picture is this, and we heard it with your question this morning with the Joanna Moncrief thing. The chemical imbalance story was formed as a hypothesis really in the mid-60s based on an understanding of how drugs acted on the brain. What was their mechanism of action, the antipsychotics or the antidepressants? So, for example, they understood that antipsychotics blocked dopamine receptors. They thwarted passages along dopaminergic pathways. So they hypothesized, well, maybe schizophrenia is due to too much dopamine. And then for depression, what they understood is the first antidepressants, they kept serotonin longer in that synaptic cleft between neurons. So what happened is they blocked the reuptake of serotonin from that gap. So up serotonergic activity. So they hypothesized, well, maybe depression is due to too little serotonin, or monoamines at the time, okay? So now they have to investigate, do people with schizophrenia, before they go on the drugs, do they have too much dopamine activity? And what you find is, even by the early 1990s, they were saying that simple dopaminergic hyperactivity theory is falling, it's just no longer credible. As early as 1984, the National Institute of Mental Health conducted an experiment into the low serotonin theory of depression, saying we're just not finding a lesion in the serotonergic systems of depressed patients. In 1998, the American Psychiatric Association's own textbook said the low serotonin theory of depression is dead. We didn't find it to be so. We've tried to find it many ways. So what happened to us? And as you also heard when James answered your question, they knew this a long time ago, and it's true, they did. So when we think about this narrative, there is this bottom line. We organized ourselves around a false narrative. And it's a narrative that says, if you have this, you're chronically ill, and basically you do need to take the medications, right? Because you have this biological problem. So that's the conceptual image that was presented to us, this disease model. And if you actually look at the science, it didn't pan out, and as also we heard today, the biological, quote, underpinnings of these disorders remain unknown. It doesn't mean there's no biology, but they remain unknown, okay? How about public health outcomes? So we get this great expansion. Here's what happened in the United States, just as one marker of an outcome on public health. We had about 1.2 million people receiving a disability payment because of a mental disorder, psychiatric disorder, in 1987. By 2007, we were up to over 4 million, and then we went to above 5 million. So you get like a tripling of the number of people on disability. How about kids? Because we didn't used to diagnose kids before 1980. We didn't medicate kids before 1980. In 1987, there were only 16,000 kids under age 18 who were seen as disabled by a psychiatric disorder. 20 years later, we were over 600,000. So what you see on a public health measure, just by the disability measures, rather than an improvement, it's a lessening of the burden of mental disorders, you're seeing a remarkable rise, at least in the United States. Then a few years ago, I was asked to give a talk to a work group at the UK Parliament on this sort of question, why are we seeing more disability? And I looked in other countries, including Iceland, and what you saw is in every country I could find in a developed world that adopted this narrative, adopted this belief system, and adopted this widespread use of drugs, there was a rise in disability. in every single country. By the way, it's mood disorders that's really driving it. And that's sort of tied with the increase in antidepressants. So on a public health level, this narrative we've organized ourselves around hasn't worked for us. Now, how about clinical outcomes? You could have a sense that, well, okay, maybe the mental health of the society is deteriorating, but nevertheless, we have this response that helps people over the long term live better lives. The symptoms go down, their functioning improves. Now, the way drugs get tested, of course, as you know, you first do to get a drug on the market, you do a short-term study, like 6 weeks, et cetera, maybe 12 weeks, whatever. And does it knock down the symptoms of that disorder better than placebo? Okay, and as long as it's a little bit better, they get approved. By the way, these studies are never done in medication-naive people. They're always done basically in people who've already been on the medications and they wash people out. So that's the short term. That's how they get proved. There's some measure of effectiveness in reducing symptoms better than placebo. Now, how about long-term use? They come from a very specific type of study. What they'll do is they'll take that group of people that have responded, say, well to an antidepressant or has responded well to an antipsychotic. And the reason why you have to isolate the well group is because we're going to do relapse studies. They have to be okay. They have to be stable before you do the study. And then what you do is you randomize people where people are withdrawn from the medication, usually rather quickly, and those maintained. And with great regularity, those withdrawn relapse at a higher rate, okay? So they're more likely to have a return of symptoms. And that is seen as evidence for long-term use because people go out off and there's a higher relapse rate. Now, the problem with that is two things. Is the higher relapse rate a return of the, quote, disease, or is it in fact a withdrawal effect? Or in other words, are you exaggerating that? Is it that the natural course of the disease, or is it a withdrawal effect? The other thing is that doesn't tell you how people are functioning after 1 year, 2 years, 5 years, and 10 years. And that's what we really want to know when we look at clinical outcomes, right? Now, so that's what I did in this book, Anatomy of an Epidemic. And real quickly, one of the things when you look at to try to assess the merits of a therapy over the long term, you have to have some understanding of what's the natural clinical course of that problem. Does that make sense? Because if in nature, there's often a capacity to recover, you have to best that natural capacity to recover for your intervention to be doing good. Does that make sense? So, for example, when antidepressants were introduced, and they become popularized in the 1970s. What was the conception of the natural course of depression? It was episodic. And even if you looked at people who had been hospitalized, the longer-term outcomes went like this. 85% of people hospitalized could be expected to have recovered and be released at the end of 1 year. If you take that cohort of 100 people, 50% would get better and never return to the hospital. There'd be another group, about 30%, maybe every 3 or 4 years, they would have an episode, and only about 20% became chronically depressed. So when antidepressants were introduced, the idea was, we're going to have a hard time improving on that long-term outcome, but maybe we can speed up the recovery level. Well, right away after they were introduced, they began to notice something odd. Maybe people were getting better faster, but it seemed like with the antidepressants now they were relapsing more frequently than before. And so you can actually go in the literature and they say, I think these drugs are causing a chronification of the disorder. People are more likely to be symptomatic years later and more likely to have functional impairment. By the 1990s, the APA was saying, oh, we misunderstood the course of depression. It used to be episodic. Now we know it's chronic. And now I want to tell you about I'm going to try to move through this a little bit faster. 2 NIMH studies related to the course of depression in modern times. NIMH is the National Institute of Mental Health. It is the major funder of research, actually the biggest funder of research in the world. They did 2 studies to look at what are the outcomes for people treated with depression and real-world patients. Real-world patients are the ones that actually exist in society. The drugs are tested in very special population, okay? The largest antidepressant trial ever conducted is known as the STAR-D trial. It's 4,100 patients who were entered, and when they mounted this trial, they said, this is going to tell us whether we can get people well and keep them well, and this is going to guide clinical care, okay? Not those drug studies. Now, they announced that 67, the way it worked was if you didn't remit on the first drug, in other words, your depression didn't go away in the first drug, you could switch to another drug and maybe psychotherapy, and you could get 4 tries on different drugs and therapies to remit, okay? You started with an antidepressant. And they said after 4 tries, 67% of the people remitted. And that's still cited today in the United States as evidence that antidepressants work. Here's the problem. That's not true. That was a fake number. And in fact, the outcomes were so poor that basically they had to have all these deviations from protocols and these mathematical calculations to exaggerate this first remission rate. We have something where you can go back and look at the data. The latest thing is actually only, I think it was 28% or 30% ever remitted during one of those 4 times, not 67. But that's not the kicker. The real kicker is how many were well at the end of 1 year, because the idea was you remit, then you get put into the follow-up trial, and we're going to do everything we can to keep you well. Here's the bottom line results of the largest antidepressant trial ever conducted. 4,041 entered the trial. At the end of 1 year, there were only 108 patients who were still well, who remitted and stayed well and in the trial to the end of 1 year. That's a stay well rate of 3%. That's the worst outcome ever. And that was not promoted by, there was actually a graphic that told us that in one of the last publications, but it wasn't promoted to the public, and it took outsiders to get access to the data to actually make this outcome known. So 3%. Within the ordinary standard of care. Well, they also funded another trial. What is the course of unmedicated depression today? And here were the outcomes at the end of 1 year. 85% were well, just like in the old day. So you have a story within the system of care, 3% stay well rates, 85% outside of care. Now that information is never presented to the public. And anyway, there's a lot of other data showing that depression runs a much more chronic course than it did before. By the way, I want to reiterate something we heard today. There are people who do fine on the drugs, okay? There are a various spectrum of outcomes. The question is, what do we as a society need to know about the long-term outcomes, and then we can figure out how they should fit into our system of care, okay? How about, though, schizophrenia? Because we all know that schizophrenia, you have to take these drugs, right? They're absolutely key to taking these drugs long-term. Well, real quick thing, and this goes back to something Andrew was saying. Between 1945 to 55, we get the antipsychotics chlorpromazine in 1955. You called it Largactil, I think. Thorazine in the United States, Largactil in Europe. Before 1945, we had these eugenic ideas about the mentally ill, and they needed to be kept they needed to be kept in hospitals to sequester them so they didn't breed, okay? There was a deliberate thing, we need to keep them away from society. But then after 45, eugenics becomes somewhat discredited. There's this idea we need to discharge people. So now you want to look at what are discharge rates for first episode patients in the US and European hospitals and Norwegian hospitals from 45 to 55. This is before antipsychotics. The discharge rates are about 2/3 in 1 year. At 5 years, you'll generally see between 65 and 75% living and out in society, and this is before you had disability sort of social support sources. So this idea that nobody got better before the antipsychotics came, that nobody recovered from psychotic episodes, is just not true, okay? We need to incorporate, by the way, this is an optimistic story. What I'm telling you is an optimistic story because what we're really hearing about is so often psychiatric difficulties can be episodic. You can have a time of difficulty if we go back to nature, as opposed to a chronic condition. Finally, real quickly, the NIMH, we had a longitudinal study that was launched in the late 70s to study the long-term course of patients diagnosed with schizophrenia. It was done by Martin Harrowett and Tom Job, and the way the study was designed, they enrolled 200 patients. Some had schizophrenia diagnosis, some had a milder psychotic disorder. They all get treated in the hospital with drugs, then they're discharged, and they're just going to be followed for 2, 4.5, 7.5, 10, 15, 20 years. The hypothesis is that the patients who stay on the drugs will have the better outcomes, because that is consistent with our understanding. So what did they find? They found that at the end of 2 years, among the 64 schizophrenia patients, 25 had quit taking their medications. And there wasn't much difference between the two groups. There was a little higher recovery rate at the end of 2 years, but most of the patients who had quit taking their drugs were still psychotic. They were still showing psychotic symptoms at year 2. So were the medicated patients, the compliant. But then between year 2 and year 4.5, these outcomes diverged dramatically. And what did he see? He saw that by the end of 4.5 years, 40% of those off medication were in recovery. Recovery was asymptomatic, hadn't been hospitalized the past year, and working or in school and having a decent social life. So it was a robust measure. Only 5% of those on medication. So what he saw through this longitudinal study is something we don't see in the relapse studies. He saw the capacity to get better in nature. And that 8-fold higher recovery rate existed throughout the 20 years. And it was those who got stable off medication remained very stable. They had very low relapse rates. What was the work level of those who got off their medication? 70, 80% returned to work. And one of the things he discovered was this. The people who had been diagnosed with schizophrenia got off their medications, they stopped going into care. They disappeared from the system. And one of them became a college professor, one of them became a lawyer, and then one was those people don't go back to their colleagues and say, hey, you know, I had a diagnosis of schizophrenia. So he said, we lost sight of these people that recovered and did well. By the way, there have been now 7 such studies, including 1 randomized studies that look at long-term outcomes. And as Martin Harrow and Tom Job wrote in their piece in 2020, none show a positive benefit for a standard of care where long-term medication is the usual course for everybody. They all had higher recovery rates for those who managed to get off. Now, that doesn't mean that there aren't some people that maybe do better with the medications long-term, but you do see what it does show us. It shows us this wonderful opportunity for some people, young people often, 19, 20, to have a time of psychosis, and with the right care to just have a time and not become a chronic patient. That's what you see in this longitudinal data. I will tell you that the one long-term NIMH study of ADHD was also negative for drugs long-term. So as our NIMH efforts to study longitudinal outcomes, they're all negative in the aggregate for depression, for ADHD, for schizophrenia. And the other thing with bipolar, there's been a dramatic expansion of the number of people diagnosed with bipolar. And if you look at the research literature, actually, those outcomes have worsened as well, okay? So what do we see with this conventional narrative? We see it is false, that we were told that we were fixing chemical imbalances. That's not true. We see bad public health outcomes. And on an individual level, it doesn't mean no one does well in the drugs, but on the individual level, aggregate outcomes actually have worsened under this paradigm of care. By the way, there was a study of recovery rates in schizophrenia in Western societies today. In the era of atypicals, it's gone down to 6%. That's the lowest it's in the 100 years that's ever been. And we also heard about mortality rates. The standard mortality rate is something where you compare the risk of dying for a group compared to the background rate for the general population. That's doubled in the last 20 years, both for bipolar patients and schizophrenia patients. Okay. That's a story of a failure. That's a story that we have organized ourselves and are thinking around a failed narrative. So now the question, and by the way, a couple years ago, and Chris was there was a meeting in India, an international meeting, and it had representatives from the World Health Organization, from the United Nations Special Rapporteur for Health. And at the end of that meeting, here was the conclusion. We have to organize our thinking around a different narrative. We need a new narrative to guide our thinking. So, now let's talk about that narrative and what is possible. And if I had time, I could read you the quotes from the World Health Organization, United Nations, etc. By the way, you heard at the introduction, I run a web magazine called Mad in America. We now have affiliates in 11 countries. There's 4 more affiliates starting in the next few months. And the reason, what do we do with this magazine? Our belief is we've organized ourselves around the false narrative, and we got to invent a new narrative, one that is more optimistic and more actually governed by two things: science and the lived experience of those who've been in the system and recovered, etc. That's the two principles. So what is the new narrative? What is possible? Well, I think part of it is you're supposed to decide. The big narrative for me is, what is a human being? We have to start with that. What is a human being? What does the past tell us? And the first thing that tells us is this: we're crazy. By this I mean we're really emotional creatures. We're built to be miserable sometimes. We're built to be jealous. We're not like these steady, straight creatures. I mean, read the Bible, read your literature, go to the theater, read your Shakespeare. How many do you see these people that just trot around nice and neatly? You don't, do you? And I love this idea that we're not who we were when we were 5. We change, that sort of thing. So the biggest thing we have to understand is suffering, difficulties, emotional turmoil. When you're growing up and even up, that's part of who we are. It's just evolution. That's who gave us this. That's the first thing. The second thing is, what are we built to do? We're built to be responsive to our environment. From the moment we're born, we are the most environmentally responsive creatures around. So once you put those two together, what do you see as a possibility for a way to do things differently? Change the environment, right? And what sort of environments do we need? Well, we heard today about how the work environments suck. I agree with that. But we're also hearing, what did you hear with all these beautiful stories? What did everybody talk about? Connection, meaning in life, people that they bonded with. So what you heard in every time is you didn't hear this. You didn't hear over here the mentally ill people, and over here are the normal people. What we need is an us. We need a sense of, to go crazy, to go depressed, that's just to be human. And we need to have a new narrative that doesn't say the other. It's got to be us. Now, the beautiful thing is now we can go back in time, in history, and see, has there been times when they had this sort of conception and what happened? And is sort of a transformation possible? Now, Andrew actually referred to this. If you go back to the mid-1700s, there were mad houses, mad doctors, and there were biological explanations for madness and depression. So, for example, the earliest text in the United States said, depression is caused by too little blood flow to the head. So what we have to do is we need to put people on a spinning board and force blood to the head. And madness was caused by too much blood to the head, so we had to bleed them and that sort of thing. They basically were the imbalanced stories of the day. But then the Quakers of York, England, who had one of their members die in a madhouse, I'm not sure exactly where the madhouse was. Now, the conception of the mentally ill at this time, the insane, was that the insane, by virtue of having lost their reason being the part that separates us from animals, had descended to a lower level of brutes, and that's why you needed to treat them as brutes, okay? They were different, they were others. And you'd see people get chained up, whipped, and that sort of thing. The Quakers said, we do not know what causes madness. That still holds true today. We've heard this. I'm sure there's many, many different pathways to depression, psychosis, etc. We'll talk about this in a second. They said they're brethren. What we know is they're brethren. Now, I'm not a religious person, but they're saying at this time they're children of God. And as children of God, there's two things. They often have a God-given capacity to recover their sanity, their reason. But even if not, we have a duty to provide as comforting a shelter as possible, as nurturing a shelter. So they built a retreat out in the country, and the idea with this was that nature, dressing up normally, not wearing sort of things, eating with each other, exercise, writing, reading rooms. They also, if you go back to the original thing, it says a glass of porter in the afternoon is a good idea. I sort of adhere to that. Porter is a wine. And you also heard, well, what were the outcomes with this? Andrew said like 40% basically discharged and maybe another 25% improved enough to return. So what you really saw, and these were, if you go to the case studies, these were really disturbed people. Many people treated with this idea of kindness, and the really thing is, as brethren, many people had a time of difficulty and then got better, okay? And you almost see like three things, like basically a time and then just a more normal return. And then another thing where they're improved, maybe they're still struggling with symptoms, but they can function in society, and then there's only about a third that really are becoming chronically ill. So that's a story from the past where you see that where you conceive of brethren, it changed things. We did have an experiment in the 1970s in the United States called the Soteria Project. It was done by the head of schizophrenia studies at the NIMH, Lauren Mosher. He had the same thing. He said, like, he believed that relationships were so important. He set up a residential house. It was run as a randomized study. Either you went to the hospital or you came to this Victorian house, which was just staffed by ordinary people who would be with them. You'd cook with them. And it was okay to be a little psychotic, okay? But the idea was with this comfort, this being with others, the psychosis might abate on its own. Now, there were, by the way, the man who ran this house for 10 years was Voice Hendricks. He was the cousin of Jimi Hendrix. And one of the things that you see why it did work is he was a personality that had this effect on you. You sit down with Voice Hendricks, and about 5 minutes later, he's just a lovely, lovely man. You say, I'm a pretty cool guy. This guy likes me. And he has that effect on you. Anyway, they ran his experiments. After 6 weeks, the psychosis abated just as much in this group, in the non-medicated group, as in the medicated group. At the end of 2 years, they had much better outcomes. And he found this in terms of, because it was, they didn't immediately medicate people with neuroleptics, but if people didn't get better, they would give them a dose. And then they would find out once people were on who could come off. And the long-term outcome data was something like 40% never exposed, 40% used for a time, and only 20% maintained on them. So it's sort of a selective use model. And you'll see that that's exactly the model that was used in open dialogue in northern Finland to such success, a selective use model. So just to conclude on this, to keep going real quickly with this narrative that I believe we should investigate at the least. We need something that says it's not about the other. It's about brethren. It's about us. And we have to understand that as part of it's part of the capacity of human beings to struggle. We have to have a sense that we are responsive to our environments, which means healthy environments can be healing. And what you saw with IPS, it's so much about connections. And the other thing is we need a scientific humility. And the humility is, I'm sure there are many different paths to psychosis. You can have like illnesses that lead to psychosis. You can have environmental toxins. Trauma can obviously be. There's a lot of different paths to depression, psychosis, setbacks in life, etc. We try to make it sound like everything is the same. What we have to have is the humility is we don't know, but there's a lot of different paths, which also open up a lot of different possibilities of different types of outcomes, okay? So that's the narrative I think we need to embrace. I think it's one that you see in science and history as what is possible. And the good part about this is it's optimistic. It's not like, oh, you're going to be chronically ill and for the rest of your life and need to take medications. This is a chance to reinvent a narrative, to re-embrace a narrative that really offers such, it's rather than this pessimistic, okay, you can be in recovery, it's really like you can have a time of difficulty and then get beyond it. So, and then I'm going to get to why I think it's so important, this meeting, and what can be done in Iceland. So in terms of clinical services, in my opinion, part of the clinical service, the experiment that you do, does have to embrace at least a selective use of drugs. So you try to figure out for who and for how long. And as part of that, because of what we heard today, when you go on these drugs, I missed one part, maybe I should go back to this. These drugs do change your brain. So if at all possible, with first episode, if you can get people through the episode without putting on, you actually see a lot of evidence that can be a good result. The part I left out, I realize, this is a really dark part of the narrative we're in now, and you don't hear much about. The dark part of the narrative is this. What we've found out is that when you, let's say you go on an antidepressant, and I don't mean to scare anybody here who's on an antidepressant, but I also believe in informed consent and information. When you go on an antidepressant, so it blocks the normal reuptake of serotonin into your presynaptic neuron, okay? And as Stephen Hyman wrote in a 1996 paper, Stephen Hyman was the director of the NIMH at this time. He's a neuroscientist. He says, the way these drugs work is they perturb normal neurotransmitter activity in the brain, and in response to that perturbation, the brain goes through a lot of compensatory adaptations, trying to maintain what they call an homeostatic equilibrium, a normal functioning. And he says at the end of this compensatory process, the brain is now operating in a manner that is both qualitatively and quantitatively different than normal. So we were told they were normalizing agents. They're really abnormalizing agents. So for example, if you go on an antidepressant which blocks this normal reuptake of serotonin, it's like putting an accelerator on it. What does your brain do? The brain being having this extraordinary feedback loops and neuroplasticity says, uh-oh, I've got to decrease my own serotonergic activity to bring it back into balance. So you'll actually put out less serotonin for a while, and your postsynaptic neurons, the ones that receive it, will actually reduce their density of receptors for that molecule. So you go on an antidepressant, and physiologically, you drive your brain into a subserotonergic state. Now, you're like this. Now, your brain got used to the drug. What happens when you take away the drug? This is why your brain got adapted to it, and for many people, you're going to have these withdrawal things. And there is a sense that sometimes it may not renormalize, and that's why you see these things that we heard about how hard it is long term. And just so you know, this is not me. If you were to talk to the researchers who ran that schizophrenia study, they said, why were the people on medication compliant much more psychotic long term? They said, oh, it's probably the drug-induced dopamine supersensitivity, this change in the brain driven by the drug. The people, mainstream researchers, you never hear about this, but it's in the scientific literature, who have looked at, well, why is depression running so much a chronic course, and why are we getting more treatment-resistant illness? They'll say the same thing. You're getting this what's called an oppositional tolerance. The drug drives your brain into the opposite state of what is originally intended. So this is the real sort of dark side of this whole way of thinking and doing things is we don't know if anything's abnormal, but you do have drugs that perturb normal functioning, and at the end of that, your brain is in this other state. And when researchers have looked at why we're getting sort of long-term, poor long-term clinical outcomes, they're pointing to this compensatory adaptation, this abnormalizing. And they're also saying this is why it's so hard to come off. Anyway, this is why I believe you want to have a form of care that, if it's at all possible, tries to get first episode people through without using the drugs. And then if you use the drugs, figure out who needs them long-term and who can come off, okay? Now, the open dialogue program in northern Finland was built on that very principle. That was operated for about 5 years. I mean, by this time, it's operated for about 20 years or more, where they used drugs in that way. With first episode, they did not put people on antipsychotics immediately. If people weren't getting better, they didn't have a grip on life, then they would use them for a time, low doses. And then after 6 months or so of those exposed, they would see who could come off and who needed to go on the drugs long term. And let's see if I can remember, at the 5-year results that they published, 2/3 of their patients had never been exposed to antipsychotics. Another 13% had used them occasionally, and 20% needed to be them on chronically. What were their outcomes? They were so much superior to anything else we see in the Western world. Basically, at the end of 5 years, 80% of their patients treated in this way, which, by the way, was intensive sort of dialogical therapy, being with people, that sort of thing. 80% were working or back in school and asymptomatic. And what if you would go there at this time and talk to Jaakko Seikkilä, said it completely changed our understanding of what was possible. One of the key things with open dialogue is they reconceived what was happening. They didn't see the problem as happening inside the brain of the individual. They said the problem is happening in the in-between spaces of people, so you have to fix those in-between spaces. And they even had this beautiful line that the person who is psychotic is making manifest known this disruption in personal spaces. They were like the messenger to the community. Now open dialogue is being exported around the world to many other countries, but it isn't being exported with this selective use of medications, which in my opinion is a problem. But that's an example of a possibility that's out there that is shown to be very effective. A second initiative that is underway is in Israel. We did mention, I think Magnus mentioned that, when he looked at Soteria projects, because the original Soteria was with the selective use of medication, he didn't find many that they were using them in this way. And that's true. That was a problem the same way that open dialogue is being adapted so often. But Israel, about 5-6 years ago, there's a psychiatrist named Pesach Lichtenberg who met Lauren Mosher from the United States. He became disenchanted with outcomes with the new atypicals. In Israel, he was the guy that was supposed to make sure that everybody used the new atypicals. And instead, he decided to revisit the original Soteria house and open up those homes in Jerusalem and then, in other parts of Israel. So I visited there. You went there. There were many unmedicated people, psychotic people. And I have to tell you, man, they were fun places to be. They really were. They were people were engaged. I'll give you an example of one thing that I first came in, and one guy's juggling balls and that sort of thing. Another guy comes up to me and he holds out his hand. He goes, I say, "Hi, I'm Bob." And he goes, "Hi, I'm God." I said, "That's nice to meet you, God." He goes, "And I'm Jesus Christ too." "That's nice to meet you, Jesus." And then a little later he goes, "Would you like to be part of my WhatsApp group?" So I said, "Well, I don't speak Hebrew." And he goes, "God translates." Anyway, and the great thing is what is happening there, and there are people there who now have had psychotic episodes, and now they're like, one guy's a composer, and you see these great things. But for various reasons in this smaller country, the Ministry of Health decided to embrace this. They're now getting health reinsurance for it. I think some of them are called Soteria houses, some of them are called equalizing houses. The one problem they're now having in Israel is got too successful. Once insurance started to cover it, they said, we're not going to cover it for 6 months, which is the original idea, or even longer, only 28 days, and that's a problem to try to do this in 28 days. But that's an example where you have a society saying we're going to do something different. The Norwegian report, 5 minutes, the Norwegian is another example of where it does come out of a different conception. And what they're doing, it's so, and by the way, 2 things that Magnus said. One thing that happened is the user groups came together, and that became a force. That would not have happened without and the user groups had plenty of differences before. But when the user groups came together to make a demand on the Minister of Health, that's what drove this change. Now, there's a lot of resistance in Norway to this as well. However, there's also MAD in Norway, one of our affiliates, and they really talk about how the discussion is really changing. So you have that, you have Israel. The other thing that, and I got involved with starting this, and there's an Icelandic connection here as well, and Magnus was involved. We started an International Institute for Psychiatric Drug Withdrawal a few years back, with the idea being that no one does know how to taper. We needed to have research and deprescribing clinics set up. Magnus was on the board. We had a meeting. I'm not sure when the first meeting was. He was one of the founding board members. We had, Udur, Axel Stodders on the faculty of that initiative and trying to bring sort of this idea to Iceland. In fact, there was the first IAPW conference was scheduled to be held in Iceland in the fall of 2020. Unfortunately, because of the pandemic, it didn't hold. So now here's the final thing for you, because now I got 3 minutes, I think, or something like that. You guys, Iceland, you can be a laboratory for change. You can talk to your government officials. And you have so much momentum all the way with what we're seeing here today, IPS. Everything I've seen is people eager for a change, these beautiful stories we heard. You've got to collect that into, for my point, for what I want, there's my wish list, is that you'll set up efforts like this? You'll set up deprescribing clinics. Can you set up a first episode place like a Soteria home? And then can you study the results? And can you look at what is possible with, if you do a deprescribing clinic, what happens when people come off? I will tell you there are many stories when people get off the medications, they feel they get their full lives back. They feel like they feel the world once again. They experience the world. You saw that in Magnus's thing. One of the things I think you said, people feel more once they come off. So the challenge for you, and the reason like I'm so happy to be here, if you're a country, you may only be 400,000 people, but if you do changes like this, and you document your changes, and you document what happens to people, that can serve as an evidence base for others to change. And that's what happened with open dialogue. So I wrote about open dialogue in the book Anatomy of an Epidemic. The reason I went to northern Finland was because they had this selective use model, and they had documented outcomes that were much, much better than in any other part of the world. And that's one of the reasons I think is that there is an evidence base for this change. You saw Magnus talking about whether there was an evidence base for medication-free treatment in Norway. There's absolutely an evidence base. What there's not an evidence base is for the form of care we have today, which says put everybody on right away, often multiple drugs, and keep them on for life. There's no evidence base for that. So if we want to get into an evidence-based argument or discussion, evidence base is saying this. There's two things saying this. The evidence base is saying this. The personal stories you hear are saying this. And our knowledge of the past is saying this as well. And our knowledge of what we human beings are saying we need a new narrative. We need an optimistic narrative. Unfortunately, I don't think it's going to come from the United States in terms of big change. We're just too under the control of bureaucrats and money. But you guys have a chance to really make a difference. And Matt in America will be watching, so thank you.
Well, thank you, Robert, Bob, to us now, for this really refreshingly blunt and eye-opening talk. I'm sure there are questions in the auditorium, so please raise your hands if you have questions. Yeah.
Again with me. Like, we have a new paradigm. We have it for a long time. You know, I did my bachelor's in 2017, interviewing people who've gone through, had to recover from serious mental illness with a recovery model and empowerment model in Hugarafl, Mind Power, you talked about. They had been doing it for 10 years, so we know all these kinds of ways, and we've seen progress, and we've seen, but it seems so hard to get those changes going on, you know. I myself is recovered, you know, from bipolar. I went through every drug in the book. I went to see all the psychiatrists, and when I found about the recovery model and empowerment, you know, I healed. I'm now a sociologist. I teach sociology of mental illness. Tell them about all these things we'll be talking about today with various students, and it's so hard to shift from the paradigm of, you know, diagnosis and medical model, you know. I introduce them to all these ideas, and then still in the final paper, they talk about a lot about diseases, diagnosis and stuff, even though they have the information.
Yeah.
And, you know, I had a session yesterday with the breathing, and for me, 45 minutes of the breathing session was better than 10 of clinical psychology session, you know. So we see evidence all around it, all around us, but still it's so hard to get these social changes going, you know. Can you talk a little bit, how can we do this? Because I burn for this.
So this is the proverbial $64 million question. You know, what's so hard is, what happens is when you get a narrative and people get invested in that narrative. And people get invested in that narrative in many different sort of gateways. There's the professionals who get taught that, and they start practicing along with that narrative. So they're invested in it. and they're not eager to change because it's too hard. Because I remember one psychiatrist, after she read Anatomy of an Epidemic, she said, okay, I think you're right. I think we're harming people with this disease model and this way we're using these drugs. But she says, now you have to tell me one thing. How do I come to work tomorrow if I change? So you're going to have some professional resistance. And there's also the money influence all over the map. There's also resistance from the population that has accepted this narrative as a guide to their life, an identity sense that I have this and I need this. So that can be a hard thing to switch out of too. Now, I know a lot of people who have switched out of it, but it was painful to do so because there was a lot of sense of like, oh, my life went down this way according to a false story. That's what happened to me, and that I sort of lost these years of my life. So even coming to that recognition, and then there's a sense that like, if you've been on these meds, it is tough to come off. So that's a reinforcement that like maybe I do need the drugs, right? I mean, this whole model. That said, so how do we change this narrative? You can see I don't know, but there are two strong things that can sort of worm their way into human beings' heads, everybody's heads. One is, what is the research telling us? Okay, what are the long-term outcome studies? What's happening in the United States, for example, by the way, a man named Nasser Ghami, who's a big biological guy, famous psychiatrist in the United States, he recently wrote a paper saying this. Listen to this. This would have been heresy 10 years ago. We have to understand these drugs are not curative. They're just treating symptoms, and we have no evidence that they provide a long-term benefit. None. This is a mainstream guy. He did have an exception for lithium. He thinks there's some benefit as a reduction for suicide with lithium. But he said we should be using these drugs in as low a dose as possible and for the shortest time as possible. So all of a sudden, creeping within the mainstream literature, there is this sense that these drugs have not improved long-term outcomes. So that's a change from 10 years ago. But how do we do it? One, and this is what we do at Mad in America, we try to make the science known. So we have daily science reports, and there's so much science about we need to be doing things differently. And two, you need to listen to people. What did we hear over and over again today? Every story told the same story. I got isolated, I was told I was something wrong with me, no one listened, and then someone listened and I formed relationships, and that's when I got better. Those are the twin things that somehow we have to keep on sounding. You sounded it brilliantly here today, here in this conference. The idea of human beings connecting with each other and peers and all. That was brilliantly sounded today. Now, unfortunately, I mean, this is a good crowd. I wish there were 5,000 people here. And I wish all of your mental health counselors were here. And I wish all the psychiatrists were here. But you're starting, and this is a powerful story, but that's the only thing I can think of. We need to hammer on the research and listen to lived experience. By the way, in the UK, they're really making progress with their critical psychiatry group, hammering on this. They're much further along. And we were at lunch, they're talking, The Guardian, major newspaper, is now receptive to this sort of criticism. And the other thing is, when you see at a public health level rising disability rates and rising burden of illness, it does open up a sense that, like, this isn't working for society. We don't want to pay for rising disability. So you get an economic thing that sometimes politicians will respond to. So, but it's a big battle. But this is why I'm pleading on Iceland to be a leader, if you can.
Oh, thank you for this.
Oh, there you are. Sorry.
Yeah, here I am. Thank you, Bob, for this great talk, speech that you had. And it's so, I was wondering, because we had these beautiful stories here earlier about connection. And this is what we do all day in Mindpower also. We have the open dialogue trainer. We have the connection in your network with Magnus also. And we have also these ECPR trainers. and peer support. And I think we can do it if we do it all together.
That's the message from Magnus.
Yeah.
Working
I think
together.
So, working together. Because it's not based on, yes, of course, money. We always need money, but we need this passion for our work. And I think that is the key. We are not doing it for money. We're doing it
I don't know anybody on this side of things getting rich, but anyway.
No, it's because of passion.
Yeah.
But thank you so much, Bob. Thank you.
Just one real quick thing. When I was doing Anatomy of an Epidemic, that book, and I was looking at people who had done well and their narratives, they all talked about relationships. Every single person talked about somebody that allowed them to envision a different future and to sort of break out of the isolation stuff. That was a common theme.
We have one more question for you.
Thank you, Bob, for the presentation. It was so inspiring. I really heard my own narrative, but I also would like to stress, as a researcher and an innovator, it's so important to go outside and also team up with people with money. Here in Iceland, you got the fishing industry. They are so wealthy, filthy rich. So why don't team up with them and ask them if they want to make a revolution? Thank you.
So that's brilliant. Can I say one thing?
Yes, please.
The presence of people getting diagnosed and sort of trapped in this is so prevalent. I bet some of those fishermen have kids that are getting trapped in the system.
Yes.
Right?
Yes.
So that can be a hook for getting some money.
And it's also an industry that has really big problems and issues with mental health.
It's a difficult job. Thank you.